We can start, Bajinder. I think she accidentally exited. All the listeners.
ఎవరు కిషన్?
Bajinder ఆమె లేదు, she exited అనుకుంటా accidentally. Let's call her.
Basjinder, you can start. Basjinder?
She's not there. I think she probably accidentally exited.
The speaker will be joining in a minute. Please be with us. We will start with this.
Yeah, she's joined. Bajinder, we can start. You can please start sharing your presentation.
Sir, am I audible?
Yes.
Yeah,
You are
please share
audible.
your presentation. Please share your PPT.
Just give me a minute. Is it not shared yet?
No.
It's visible now, sir?
Yes.
Yes, it is. Put the slideshow on if possible. Yeah, you can.
So good morning, everyone. Once again, we are with the topic biomarkers in ICU. Greetings from my side and my institute. So just revising the same list, I hope everybody is remembering that we discussed in detail about the biomarkers, their origin, their types, their classification, their application. And we could cover the pathogen responsive biomarkers and host response biomarkers we were on. And we extensively covered ESR, metabolic biomarkers, CRP, PCT we could cover. And now from here, we'll be continuing with the list. So CRP, PCT, they basically do not differentiate between SARS and sepsis, a point to be very clearly remembered. So I have just tried to enumerate a few difference between the CRP and PCT, which are clinically applicable in our day-to-day practice. So C-reactive protein is acute phase protein, procalcitonin is a homokinin, liver is the source for C-reactive protein, and we have learned that in stress or in critical illness, virtually all cells, they start releasing PCT. The time to increase after insult is the earliest by procalcitonin, and C-reactive protein, it takes little more time, 4 to 6 hours. And the half-life for CRP is 19 hours and PCT is 22 to 35. The main aim to learn is that steroids, immunosuppression, neutropenia, and renal failure, and renal replacement therapy, it's seen that they don't show any effect on CRP, but we get oftenly false negative results in steroid, immunosuppression, and neutropenic patients. While in renal failure, the PCT can rise, and in renal replacement therapy, it can decrease. But still, I will say it depends on your clinical features of the patient and the way towards which we are heading with the help of our empirical therapy. In CLD, it's seen that it decreases, CRP decreases about 70% of the normal, as we learned that CRP is mainly secreted from liver, but acute liver failure, it has no effect on CRP. And while PCT has no relation with the ALD or CLD. While as we learned that in secondary infection, that is in the secondary hit, which was a marker, which was a property of ideal biomarker, that it should not decrease, but CRP decreases by 70% of the first episode, and PCT further decreases. It is only 10% of the first episode. So they are not near to an ideal biomarker. So algorithm, it is suggested that how we should incorporate CRP or PCT in our clinical risk stratification in diagnosis and management. So you, whenever you get a patient who is normal, that is not immunocompromised, and he's not having the conditions or the closed infections or the infections which require longer antibacterial agents like infective endocarditis, Staph aureus bacteremia, and osteomyelitis, you just see the SOFA score. If it gets increased by 2 or more than 2 points, or patient is in shock, you obtain cultures, you start appropriate antimicrobial therapy within 1 or 3 hours, depending upon the sepsis or the shock, and then you obtain CRP or the PCT baseline levels. Then you do daily patient reevaluation, reassess after every 3 to 5 days of antibiotic therapy. If there is, then you have to assess 2 points. Is the SOFA score decreasing, or is there any progressive improvement of clinical and lab signs of infection? If they are present, if you are getting all these features, then the recommendations are you give 5 full days and antibiotic therapy, or you give 7 full days of antibiotic therapy regardless of the biomarkers. But if you're giving 5 days full day therapy of antibiotics, then see if the PCT decreases more than 80 to 90% of the baseline and CRP decreases more than 50%, then you can decrease the antibiotics at 5 days. But if your patient is not improving, the SOFA has not decreased, then you have to rethink about everything. Is it a diagnosis related issue? Is it a drug related issue? Or there is a persistent focus of infection which we are not able to cover, multi-resistant bacteria, or there is some overlapping other infection is there. So if in these conditions patient is clinically stable, consider stopping antimicrobial therapy after 7 full days. So the crux of everything which we have learned till now is do not use CRP or PCT as the sole criteria to initiate your antimicrobial therapies. So coming next on to proadrenomedulin, it is produced by various tissues following injury to the cell. Main actions are vasodilatory, antimicrobial, and anti-inflammatory. Here we are learning proadrenomedulin in sepsis. It is produced by brain, lung, heart, adipose tissue, and kidney. It is basically an endothelial dysfunction marker, but also a marker of congestion. We learn that in our cardiac biomarkers in ICU. It allows for monitoring of organic failure and systemic congestion. Few eye-catching points about adrenomedulin are that it is higher in sepsis than SIRS. It can differentiate sepsis from SIRS. It is increased in focal infections. So these three were our basic. What we discussed was that an ideal biomarker should be able to do, and also mid-regional proadrenomedulin in sepsis has negative predictive value of more than 90% if it is less than 0.88 millimoles per liter. But the drawbacks are it is costly, it's not available, and its levels are also raised in heart failure. So its value becomes limited in sepsis, but still it can prove as near to ideal biomarker in certain situations. So here you can see that in the sepsis condition, if you get the patient has not yet gone into shock, so BP has not yet decreased, but in the initial 1 or 2 days, the bioadrenomedulin levels are elevated above normal even before the onset of the septic shock. So it can be a prognostic marker, it can be diagnostic marker to tell you that your patient is likely to go into shock, septic shock in the coming days. So when there will be a treatment, appropriate antimicrobial therapy and other interventions to treat the underlying condition, if the bioadrenomedulin level decreases, this means your treatment has responded, and if it does not decrease, this means it is not responsive. So coming on to the next, there are two type of receptor biomarkers. one is STREM1 and another is SUPAR. STREM is soluble triggering receptor expressed on the myeloid 1 receptor. It is basically expressed on both bacteria and fungus. You can see this is our myeloid cell, and in the early stages of infection on the myeloid cell, and this is our TREM1 molecule. So it gets attached to the myeloid cell and it triggers it, which leads on to the activation of TREM1 signaling, and there is activation of innate immune response, and there is a generalized sensitivity reaction to the infection in the body. And here you can see there is high mobility group box 1 molecule also, which is secreted by the cell lysis. This is also an important cell biomarker in the ICU, infection biomarker in the ICU, which is caused by the cell lysis. And on the other side, you can see if there is severe infection, more of the myeloid cells, they get triggered by this molecule on the receptors, and there is more severe inflammatory response. So it is directly proportional to the load of the infection. So STREM1, it is sensitivity is 82%, specificity 86%, depending upon its levels, directly proportional to mortality. And it's the good thing about it is that its levels, it parallels towards its outcome, that is rapidity. It is similar to lactate. As the lactate rises rapidly, we can say the patient is deteriorating. When the lactates get cleared rapidly, we can say that our intervention is working. So same way, STREM1 levels also, they parallels to the outcome. But in myocardial infarction also, the STREM1 levels can rise. So we should be vigilant. Another receptor-based biomarker is SUPAR, that is soluble urokinase type plasminogen activator. It's a prognostic marker, and it also upregulates and release monocytes and T lymphocytes in response to bacterial components, and it has more of prognostic value in mortality. So the next are cell marker based biomarkers. These are Presepsin and CD64. So here you can see that here is the monocyte and the macrophage, and here is the bacteria. These two are the components of the bacteria. These are lipopolysaccharide binding protein and lipopolysaccharide. This is binding protein and this is lipopolysaccharide. And on the surface of monocyte or macrophage, this is MCD. MCD is also two components, one soluble component and one is the membrane bound, CD14. So what happens is bacteria that forms a complex with the soluble CD14, and in the presence of cathepsin D, we can diagnose it as presepsin. So as the name suggests, it can be detected before even you make the diagnosis of sepsis. That's why it is called presepsin. So this is the basic mechanism how presepsin is formed by the bacterial lipopolysaccharide and monocyte macrophage MCD14 soluble receptor complex. So Presepsin as a novel sepsis biomarker, it was in quite discussion in the recent past. So the results from the various studies were that compared with other markers, Presepsin seems to have a better sensitivity and specificity in the diagnosis of sepsis. Is a biomarker. This biomarker is not only suitable for the early diagnosis of sepsis, but also for the assessment of severity and prognosis. And some have even come to the conclusion that it is a better marker than the PCT. So there was this Albios trial where they have taken different patients, 100 patients with severe sepsis and septic shock, and they could see that the presepsin levels were significantly higher in the dead patients who had severe sepsis or septic shock leading on to mortality, and clearly indicating that it is directly proportional to the mortality. So presepsin, it is increases within 2 hours of sepsin onset, whereas we have learned that CRP was 4 hours and PCT was also 2 to 4 hours. Its half-life is 4 to 5 hours. Studies have shown that it is useful in diagnosis and evaluation of prognosis. The sensitivity is 71 to 72%, specificity around highest 86%, and has a negative predictive value about 71%. But the disadvantages which I could gather from literature was that it rises in chronic hepatitis B also. Pathology I couldn't get. And the biggest pitfall was that it do not rise in UTI. Still the pathology is not known, but UTI, it forms major chunk of our patients in the ICU. So it has a disadvantage that it do not rise in the UTI. Another cell marker based biomarker is CD64. It is also both diagnostic and prognostic, rises within 2 to 6 hours with expression on monocytes and polymorphic cells, and its level decreases within 40 hours after removal of the initial stimulus. So last in the septic biomarkers, we have learned that there was a SIRS phase, there was a CARS phase, which was compensatory anti-inflammatory response syndrome, where our own immune system tries to limit the pro-inflammatory markers so that our organs don't get damaged by our innate immunity itself. So in the CARS phase, as we learned that 10% mortality occurs in the initial phase, that is during SIRS, and 30% mortality occurs during this CARS phase, which leads on to maybe mortality or maybe recovery of the patient. So there are some biomarkers. If we can judge about our own immune system, that how our immune system is behaving at this presence, and can we do certain interventions like we give a granulocyte forming GSCCF. So all those interventions can be done if we can judge that how our immune system is there. So basically, innate immune system is based on dendritic cells, macrophage, neutrophils, and natural killer cells. Dendritics, macrophages, they all have this tumor necrosing factor, interleukin 12. HLA-DR also is coming in a big way to, if we can measure this or we can see its expression, so that we can come to know that where do our innate immunity stands. Also the interferon gamma, which is a useful marker for sepsis survival. So we can, there are many markers regarding our immune system which can be judged, and the respective pharmacotherapy can be given accordingly. Last but not the least, neutrophil to lymphocytic ratio. The normal is less than 3. It rises within 6 hours of infection, this ratio, and several studies have shown that NLR correlates with Apache 2 score and SOFA score. So if NLR is less than 3, septic shock is unlikely, and as the value increases, you can consider septic shock or consider strongly the presence of septic shock. The sensitivity of neutrophilic lymphocytic ratio is more than 3. The sensitivity when the neutrophil lymphocytic ratio is more than 3 was 96% with specificity of only 10%. But as the ratio increases, the sensitivity and specificity both increases. So this was till here we have covered in general about the biomarkers and the biomarkers in septic shock. Now I have tried to accumulate systemize the biomarkers. There are huge lists about all the biomarkers, but I have tried to calculate only the common pathologies which we encounter in the ICU and the corresponding pathogens or the corresponding biomarkers which are easily available, and we can see who have the prognostic or the diagnostic value. So firstly, in the neurocritical care patients, we know that in ICU, we get neurocritical care patients in the form of who have intracranial hypertension, ischemic stroke, intracerebral hemorrhage, traumatic brain injury, subarachnoid hemorrhage followed by vasospasm in few of the patients in the subsequent days, status epilepticus, and the cardiac injury because of the neural issues. So these are the tests which are diagnostic for these diseases. And this is the list of potential biomarkers corresponding to these diseases. Like in intracranial hypertension, interleukin 6 can be measured. In ischemic stroke, S100B can be measured. In ICH, the leptin can be measured. And in traumatic brain injury, S100B and neuron-specific enolase both can be measured. And uticulin related receptor is also there in status epilepticus. We'll see a slide about all these biomarkers. So what are the structures affected corresponding to these biomarkers when they're released, and where we can see them? We can see them in CSF and blood. So S100B, which we'll be discussing, it is released by the astroglial cells and it is elevated both in CSF and blood. We'll be discussing neuron-specific enolase. It is secreted by when the neuron gets damaged, and it is elevated but in CSF, but it can be confounded by RBC lysis. And uticulin related receptor is also released by the neuron damage, and it is elevated in both CSF and blood. And also one metalloprotein, matrix metalloprotein, which is released when there is damage to the blood-brain barrier, and this can also be measured in CSF and blood. So just few lines about S100B. It can be detected in blood and CSF. A few studies ensured that S100B is elevated in subarachnoid hemorrhage as compared to healthy subjects and is associated with vasospasm and poor outcome. EVD drains in SCH is associated with decreased blood levels of this biomarker. So it can be a confounding factor to its usability. Major limitation is its acceptable range. It has not been yet mentioned. And the other drawback is it has a shortest half-life, so making it relevant only in most severe forms of brain injury and not in mild to moderate brain injury patients. Neuron-specific enolase, it's a glycolytic enzymes found predominantly in the neural cytoplasm. It has shown sensitivity or specificity in traumatic brain injury, stroke, and cardiac arrest, and does not appear to exhibit age-dependent liabilities, which are seen in S100B. Ubiquitin C-terminal hydrolase L1, it is formed, as we learned, by neurodestruction at increased blood-brain barrier permeability. This can be readily detected in CSF blood very early after brain injury. And the last one, metallopeptidase. This is also a proteolytic enzyme, and we have learned that it is released when there is blood-brain barrier damage. The presence of it by the two components, that is MMP2 and MMP9, has been implicated as a negative prognostic factor in stroke. And its biggest advantage is that if there is hemorrhage caused by the tissue plasminogen activator in stroke patients, its levels rises. So the higher levels are associated with thrombolysis failure also, when it after thrombolysis hemorrhage occurs. So MMP9 has also been correlated with hemorrhage transformation and malignant cerebral edema in acute ischemic stroke. So coming on to the next system, that is respiratory. From there, I have brought only just few lines. CRP in community acquired pneumonia in ICU. CRP and PCT are the more commonly used biomarkers. In CRP, a positive CRP of more than 100 milligram per deciliter on admission is a sensitive and a specific marker for pneumonia. Serial monitoring for measuring response to treatment. If there is failure of CRP to reduce by less than 50% within 4 days of initiation of treatment, suggest failure of treatment or onset of complications like empyema. And PCT we have learned. So in pneumonia, there can be, a patient can easily respond and go back home, but there can be prolonged sequelae even after discharge, like morbidity and mortality because of the cardiac complications. So in CAP, one is CRP PCT, second, you can monitor the cardiac biomarkers also, and third, you can monitor the adjacent host specific biomarkers to the sepsis. So all this will be the constellations for biomarkers for severe CAP. Next is the cardiac biomarkers in ICU. So firstly, we should know that what are the different presentations of patients in the form of cardiac disease in ICU, which we encountered in our day-to-day practice. So the common cardiac conditions in ICU, one is the cardiac dysfunction itself, and then brain natriuretic peptide is the biomarker. Heart failure can occur. The troponins or the BNP can be the marker. Cardiac necrosis, specifically where the cardiac troponins, they get increased, and also the heart phase, the FAP protein, it will be raised. Then cardiac ischemia can occur, and in cardiac ischemia, we'll learn in the next slide also, there can be inflammatory markers, and then can be the plaque rupture or instability markers. If there is inflammatory phase and plaque rupture phase, both of them markers can be, inflammatory markers can be CRP, IL-6, IL-18, myeloperoxidase, and plaque rupture biomarkers can be the BNP and the whole cell choline. Another subset of the patients which we get in ICU, where common cardiac ailments are seen, is sepsis-related myocardial depression. So here your cardiac troponin and BNP levels can be measured when you suspect cardiac involvement in septic patients. Also, cases of pulmonary embolism, where your cardiac troponin and BNP levels can be helpful when you suspect the right heart strain, along with your echo findings, or hypotension is persistent, along with your invasive investigations. So they can help you to find cardiac involvement in pulmonary embolism. So how does the cardiac biomarkers they develop? So we all know when there is endothelial damage and when there is inflammation at a site in the coronary arteries, that leads to plaque formation. Plaque formation, then plaque gets destabilized. It causes myocardial ischemia when there is partial perfusion still present to the cardiac tissue. But when there is complete occlusion, or when cardiac tissue becomes dead, then the cardiac necrosis occur, and then the cardiac troponin and creatinine CPKMB is released, and also the heart specific fat proteins are released, and myoglobin is released. So this is the stage when these biomarkers will be released. This further leads on to cardiac damage, which can lead to heart failure, and wherever BNP comes into picture, or it can cause myocardial stress, where BNP, anti-proBNP, or adrenomedullin, all these biomarkers, they come into picture. So we should know that if we have reached this stage, or we are here at cardiac necrosis, or we are here at myocardial ischemia, so respective biomarkers will be increasing depending upon their pathology. So going through the course of inflammation, inflammatory markers will be released, acute injury biomarkers will be released, and there will be, because of the injury, there is a stress on the heart. It has got pressure overload or volume overload, the respective biomarkers will increase. So in short, we all know about the myoglobin rise. Immediately, these are hours, 0 to 6 hours, rise of myoglobin immediately after myocardial ischemia. The release of cardiac troponin within a few hours, like 6 to 8 hours, it peaks, and the rise of creatinine kinase MB within like around 72 hours. So when the initial one is to rise is myoglobin, followed by the troponin, which peaks at 4 to 6 hours, and it remains in the body for 7 to 10 days. And the CPKMB is slightly late to rise, and its level becomes down earlier than the other ones. So here is the chest pain or the angina, and these are the hours by which subsequently these enzymes will raise. And here, if the angina is not treated, it can lead on to myocardial infarction. So we all have learned about these biomarkers since from the beginning, but just few salient points I'll be enumerating. CPKMB is a sensitive marker of MI, but not specific. Cardiac troponins, they both diagnose that myocardial ischemia or the necrosis have occurred, and they also prognosticate. Cardiac troponin T specifically, among the troponins, we have 3 troponins. Among that T in CRF is the better predictor of worse outcome as compared to I. Heart type fatty acid binding protein, that is HFAP, it is released by both ischemia and necrosis. Unlike the troponin, which is released only when there is necrosis, it rises in 1 to 3 hours, normalizes in 12 to 24 hours. It's a good biomarker as compared to troponin, but it's less available. BNP, which is the inactive form, half-life is 2 to 20 minutes, and more than 100 picogram per ml levels, it's indicated of CCF. Anti-proBNP, which is the active form of the BNP, half-life is 60 to 120 minutes, it gets cleared by the kidney, and values of more than 500 nanogram per ml are diagnostic for the pressure or the volume overload or a heart failure. Adrenomedullin also causes pressure and volume overload, and it correlates with the severity. So we should always remember, when we are using these biomarkers as a diagnostic approach in cardiac injury, that is, they can be elevated in other condition also, like when there is pulmonary embolism, when there is renal failure, when there is sepsis related myocardial dysfunction, or when there is SIRS or Takasabu cardiomyopathy, etc. So few words about non-coronary artery pathologies in ICU, that is acute pulmonary embolism. As I told, troponin markers, they can be both diagnostic and prognosis of patients with pulmonary embolism. So elevation of cardiac troponin can be a marker of reduced myocardial perfusion, which can cause right ventricular ischemia or microinfarction, and increased wall stress because of the occlusion in pulmonary artery flow, leading on to elevation of BNP. So cardiac troponin and BNP itself, they have less specificity in case of pulmonary embolism, but when they are combined with the echo features of cardiac dysfunction and hypotension, then they have high specificity, and they mark more than 15% mortality in such patients. So in sepsis, elevated cardiac troponin, they have higher mortality, and we have seen that 12 to 85% of the ICU patient with sepsis have raised cardiac troponins. There are various pathologies which has been prescribed for this elevation, and ultimately that it's a global systolic dysfunction of the heart, left heart. In renal failure, because the baseline serum creatinine, baseline cardiac troponin levels are already elevated in chronic renal failure, the diagnosis of MI is based on more than 20% increase in levels at 6 to 9 hours at presentation. So little higher range is accepted. So we should keep in mind that was regarding cardiac proponents. Regarding circulating BNP, we should always remember that there are many factors which are contributing in favor or in its rising levels or in its decreasing levels. So when you have given fluid, your patient is on dialysis, there is a brain injury, there is renal dysfunction, there is cardiac cause, all this can increase or decrease your BNP levels. And also some of the non-modifiable factors are age, biological variation, and gender. So we should know when our patient is on mechanical ventilation, how PEEP can increase it, how tidal volume can affect it. So all these factors we should keep in mind. So coming on to next, that is, this was all regarding cardiac biomarkers. Next, abdominal sepsis. Abdominal sepsis, mainly we have the intestinal integrity in our mind. So depending upon that, it can be divided into primary, secondary, and tertiary abdominal sepsis. Primary is when there is no breach in the integrity of GI tract and monomicrobial infection is expected. Secondary, when their perforation occurs and polymicrobial infection is expected. And third is when there is persistent or recurrent peritoneal infection. We are not able to treat it. Then the nosocomial organisms are affected. So there are sepsis biomarkers which are related to sepsis, abdominal sepsis. These are generalized biomarkers, and some newer biomarkers which are specific to abdominal sepsis. In CRP, I'll quickly read because these are all the observations from various studies. And again, I repeat that our judgment depends upon bedside. When we stand on the bedside of the patient, see how the biomarkers are behaving and how the clinical condition of the patient is behaving. So we will combine all those factors. So CRP, what the studies have seen that in uncomplicated abdominal surgeries, there is a rise in the post-op day 1. It peaks on post-op day 2 to 3, and it starts declining on the post-op day 4 and returns to baseline on day 5. If there is persistently high CRP after 4th day, or there is an initial dip in the CRP, but then it has again risen up, so it can be a strong indicator of abdominal sepsis, that is, there is abscess formation or your anastomosis has leaked now after surgery. So therefore, monitor CRP during first week following surgery. And it level, and as we have read, it can be affected by the medications like steroids, which may be there in the patient for ARDS or septic shock, along with abdominal sepsis. Next is a PCT, it rises in 3 to 6 hours, bacterial, good indicator for bacterial infections. Only merit is that it is less affected by the surgical injury as compared to CRP. So studies have shown that in colorectal surgeries on post-op day 5, with the cutoff value of 1.25, with the sensitivity of 78% and specificity of 88%, PCT could diagnose intra-abdominal sepsis. So it can differentiate complicated acute appendicitis also. It has high sensitivity in predicting infected pancreatic the infections of the infected pancreatic necrosis and its complications like ascending cholangitis and sepsis. It can assess this infected necrosis. Next is interleukin 6. It is the earliest marker to rise following wound closure, peaks on the day 1 and declines and reaches on post-op day 3. So these are the generalized biomarkers of any sepsis which I have spoken in relation to abdominal sepsis. Newer biomarkers specific to abdominal sepsis is Presepsin, the damage-associated molecular patterns, serum amyloid A, circulating messenger RNAs, which are very promising, but these are not available, and yet we need more studies to get their levels and cutoff values to be seen. Biomarkers in peritoneal fluids and biomarkers of fungal sepsis. So Presepsin, we have learned that it's short half-life, about 4 hours, and the earliest marker to rise. It potentially distinguish gram-negative from gram-positive, and studies have shown that it predicts the onset of sepsis and the mortality risk in patients undergoing emergency surgeries from abdominal infections as compared to the other biomarkers. Studies have also shown that in colorectal surgeries in the post-op period, there is a unique time course of Presepsin stability. Its value remains stable for post-op day 3 and then start rising from post-op day 4 to 6 in infected group. But as we see that CRP and PCT, they immediately jump after the surgery and they gradually decline in the subsequent days, irrespective of the infectious complications. So here the Presepsin can be a promising biomarker. And also it is an attractive biomarker to diagnose anastomotic leaks following colorectal surgeries. Damage-associated molecular proteins, HMGB1, that is high mobility group box 1. It's a best known DAM. I have discussed here because I couldn't do it in the sepsis. Biomarkers, it regulates the activity of the innate immune response, is positively correlated with sepsis severity after surgery and trauma, and it is found in peritonitis compared to control group, is a late marker of sepsis. It starts rising after 8 to 72 hours of onset of sepsis as compared to the other ones. Another marker for abdominal sepsis is pancreatic stone protein. It is mostly produced by pancreas and intestines, and it is a predictor of outcome in ICU patient with peritonitis. And the serial measurements of PCP, that is pancreatic stone protein, among patients with intra-abdominal infections or postoperative peritonitis, it predicts new onset sepsis or need for escalation of treatment or readmission if you have discharged the patient. Another abdominal sepsis biomarkers are serum amyloid A, which is also acute phase reactant formed in the liver. As I had shown you, when the CRP was formed, another short chain molecule was serum amyloid A. It rises late 14 to 16 hours of human endotoxemia, therefore helps in early distinction of sepsis from SIRS in surgical patients. So because it rises late and it's a septic biomarker, so we can easily conclude from its rising that it's sepsis and not SIRS. Circulating messenger RNAs, these are earlier predictors of abdominal sepsis as compared to all the proteinaceous markers which I have discussed now. These are the these are the genomics. So these are the earlier predictors. But as I mentioned, there are much studies to be done still to come to conclusion regarding messenger RNAs. So there is something called as peritoneal cytokine storm. What studies have shown, there is fairly high concentration of peritoneal, all these cytokines in the peritoneal fluid itself. When even the plasma can have their low values, but there can be much higher concentration in peritoneal. So a gradient is formed between the peritoneal fluid and plasma. But only when there is saturation inside the peritoneal fluid of these biomarkers, they then go to the plasma. So hence cytokines appear in the plasma only after there is saturation in the peritoneal cavity. So peritoneal cavity or peritoneal fluid can be a good source to judge the biomarkers. What are the limitations of biomarkers of abdominal specific? They are not specific to abdominal sepsis, but they are generalized sepsis biomarkers. They are still not able to differentiate whether it is a localized infection or they have risen because of the overt sepsis. Biomarkers like interleukin-6 and messenger RNA not very specific to abdomen and yet to be studied. Peritoneal biomarkers, they are not easily measurable and they are less studied. So this was all about abdominal sepsis biomarkers. Coming on to the renal biomarkers. Quickly, as we all know that there is a time gap when actually the GFR decreases in any acute injury in the ICU and when our most commonly measured serum creatinine value starts rising. So this graph shows that here is the serum creatinine, here is the glomerular filtration rate, and here is the time during which the injury was occurring. So as you can see, the GFR has started falling very early during the time period when the kidney is hit in ICU, right? But the serum creatinine rises little late. So there was a gap, this much of gap between the fall in the GFR and the rise of creatinine, window period of 8 to 48 hours when there is a need if some novel biomarker is available and it can detect AKI as compared to the traditional biomarkers like creatinine and all. So this is the point where we need to give stress so that we can diagnose early and we can do early interventions to stop the further progression of acute kidney injury to acute kidney disease and acute kidney disease to CKD. So kidney injury has been divided into three forms basically. When on the nephrons there is stress, there is structural damage, or there is functional damage to the nephrons. So in this diagram, you can see this side is the structural injury and the NGAL is the commonest biomarker for structural injury. This side is the functional hampering on functional injury, which is diagnosed by serum creatinine and cystatin C in nephrology patients. Now, there can be different permutation and combination, and there can be different stages. So we should be very clear that when the structural biomarker rises and when the functional biomarker rises, what type of injury we are dealing with, and we should halt then and there the process so that it should not go further to kidney damage and need of any renal replacement therapy. So in the first column, you can see there is no damage and there is stable GFR. So no biomarker will be released and even the creatinine will be stable. So no AKI. But when there is structural damage, but there is no functional damage, your injury marker will be raised, but your creatinine will be still stable. So this is subclinical AKI. Another situation where your structural damage is there is low, but there is decreased. I mean, there is no damage, but there is decreased GFR. The opposite will occur, and this is functional AKI. And here is the condition where your structural damage marker will be risen, and also there will be elevated serum creatinine. So this is the AKI. So quickly, this from the glomerulus we release, it is released serum creatinine and cystine C, and podocytes, nephrin, and interleukin 6. So corresponding biomarkers. And these are the functional markers, stress markers, and the damage markers, which depending upon the part of the kidney unit from where it is released, we can diagnose that at this part some injury has is been suspected. Like the functional biomarkers of PCT can be alpha protein, glutathione, and natrin 1, and NGAL can be the tubular cells in general, and distal tubular cells, and others like various renal tissues, not only the nephron, and non-renal tissues. It can be calciprotein, interleukin 18, and also CCL14, which was given by the Ruby study, and also a functional biomarker, that is urine output. So depending upon the location or the injury happened to which part of the nephron, it can be judged. Also, from where we can get, from plasma or urine, what stress markers we can get, what damage markers we can get, and one functional markers we can give. From plasma, we can get cystatin C. From damage marker in plasma, it is NGAL and hepcidin, and stress markers, they are only available from the urine sample. So again, repeating my same thing, subacute AKI, AKI stage 1, 2, 3, and here the tubular injury has happened. So you can judge from here if your functional biomarker has risen or damage biomarker has risen, that at what stage of acute kidney injury you are there. So in RRT, these biomarkers, they can also help in renal replacement therapy initiation and stopping of renal replacement therapy. RRT initiation, urinary NGAL is of helpful, and stopping of RRT, serum NGAL if there is AKI without sepsis, urine output if there is AKI with sepsis. So here also, to make the differential diagnosis in established AKI, whether it's functional or structural, the tests which are available, which are doing in a routine practice, and the biomarkers corresponding to these stages are available. So in DDs, for structural, we go for a biopsy, we do the urine microscopy, but we can also see the NGAL, interleukin 18. In early detection, for functional, we do serum creatinine, but we can also do cystatin C and confirm even in the earlier stages. Structural damage to see, we do biopsy in our conventional tests, but we can see the NGAL, Fab protein, interleukin 18, all these tests. And in prognosis also, in functional, we follow the Akin criteria and the Rifle criteria. But in biomarkers, cystatin C can be helpful, and it is also helpful in initiating the RRT. And in structure, in prognosis, after we have done the biopsy and urine microscopy, the biomarkers which are relevant to the mortality are the NGAL, interleukin 18, and FAB-P. And also, as I discussed, that initiation and stopping of RRT can also be diagnosed with the help, decision can be taken with the help of biomarkers. So again, same, this is the normal kidney, here is the increased risk where you have to do the primary intervention. You can assess that there is a risk to kidney injury by the biomarkers. You can diagnose that there is some injury happening, and with the primary prevention like hydration and avoiding the nephrotoxic drugs, treating the underlying cause, infection, you can do intervention right here and halt this procedure, halt this process to go on further. Then is secondary prevention, when there's damage has occurred and before the decrease in fall of GFR and then further rise in creatinine, you can do the biomarkers which can tell you that we are at this stage of the damage, and you can further do secondary prevention like initiate RRT here and halt the process there. But there are again many studies in pro and cons of early and late RRT. And then therapy, that is RRT or diuretic stress test, when it fails, there are other prognostic markers which help you to tell that initiation and termination of therapy, and also the prognosis in AKI. It's the same. And one thing I wanted to mention was the renal angina index. Renal angina index, it is similar like we do for the cardiac index. So renal angina index is AK risk score into AK injury score. The range is 1 to 14. If your renal angina index by combining of risk and injury, it comes more than 8 and there are biomarkers detected depending upon the stress, structural damage or functional biomarker, you can assess that your kidney is at risk of injury. So in acute kidney injury risk, there is parameters are ICU admission, history of organ transplantation, vasopressor support or mechanical ventilation, and accordingly the score is given. Then is the acute kidney injury, estimated change in creatinine clearance from baseline and the corresponding SCOTY score. It is the same thing as you suspect that in a cardiac patient there is chest pain and angina. And when you see that the cardiac biomarkers have risen up, you confirm the diagnosis of ACS if the patient has clinically come with the symptoms. And similarly, with the renal angina index, you can assess your kidney which is at risk. So this was all about the renal. Coming on to the last part, that is neuroendocrine immune system. As the name has suggested, that we encounter many pathologies and there are few biomarkers corresponding to this neuroendocrine immune system involved basically in our critically ill patients. So in any endocrine, whether it is adrenal involvement, it is gonadal involvement, it is thyroid involvement, the disease is always progresses in acute and chronic phase. So how does it, has the name suggest, this is neuroendocrine immune. So this is the nervous system which is acting, and this is the endocrine, various endocrine organs which are involved, and this is the immune system which is totally controlled by all these three parameters. And we will see that how this control of immune system basically by the glucocorticoids, how does it prevents the cytokine storm, and how does it behaves in acute illness and chronic illness. So you can see here is supposedly we are taking the, okay, let's move to the next slide. Okay, so here is your hypothalamus, here is pituitary, and here is adrenal gland. So this is called hypothalamus pituitary adrenal gland axis, and here in the periphery these are immune cells. Okay, so when a stimulus comes, cortico releasing hormone, then is the hypothalamus releasing hormone, then is the pituitary releasing hormone, then is the adrenocortico releasing hormone. It stimulates the adrenal gland which releases the glucocorticoid, and this release of glucocorticoids, this side it is pro-inflammatory on the peripheries when it acts on the immune system, pro-inflammatory cytokines which act on in all the three levels, and they further enhance the steroid levels. And also this is the early innate immune response, and this is the late acquired immune response. So what happens is both these responses, they stimulate on these three levels and stimulate steroids further. But at the level of the innate immune response, that is a generalized response, there is a negative inhibition. So the glucocorticoids, they tend to decrease the release of pro-inflammatory biomarkers, and it increases the anti-inflammatory biomarkers. So here is the condition, like it inhibits the stimulation of these biomarkers or the cytokines, and inhibits the cytokine storm. So HP axis, hypothalamus pituitary adrenal axis, in different phases of critical illness. First is in the first few hours or hours, few minutes or hours of sepsis or hyperinflammation, then proceeding on to hours or days, and then when the illness is of more than 4 weeks. So when there is a sepsis or any kind of stress for few minutes or hours, there is release of corticotrophin releasing hormone, and also arginine vasopressin from posterior, stimulating from the secreted from the posterior pituitary. From anterior pituitary, we have ACTH, adrenocorticotrophin releasing hormone. It stimulates the adrenal gland, and there is glucocorticoid production. And cortisol is in two forms. One is free form, another one is that is bound to the proteins or the globulins. So there is more availability of free cortisol in the initial phases of any sepsis or infection, and it has then it do its effect on the end organs, like it decreases the pro-inflammatory markers, it controls your vasopressor response in case of septic shock, and all those organs. Now as the disease progresses, what happens is that here the process is similar, but here occurs the negative inhibition of ACTH, and less of the glucocorticoid is stimulated, but still there is high form of free cortisol available because its metabolism is decreased. Production is less, but the metabolism is also less, then still free cortisol is there. As the disease progresses to more than 4 weeks, along with this negative inhibition of because ACTH is not being produced, there occurs necrosis of adrenal gland. So there will be decreased production of glucocorticoids, and also its metabolism is, because it's not there, metabolism is not there, binding is not there. So the free cortisol is lesser in these conditions, its availability. So what are the biomarkers now for this neuroendocrine immune system? One is copeptin. It is the precursor of ADH or AVP, surrogate marker. Free cortisol and copeptin serum concentrations, they are significantly high in critically ill patients who were non-survivors, the studies have shown. Free cortisol can be independent predictor of 30-day mortality, but still this statement does not hold true because you have to see other parameters also. Corticosteroid related insufficiency in critical illness. Three reasons are there basically. CRP is we see oftenly in our ICUs. Three reasons basically for this are dysregulation of HPA axis, alteration in cortisol metabolism, and tissue resistance of glucocorticoids. All these three we have discussed in the last slide. Next is the hypothalamus pituitary thyroid axis. So what happens is from the thalamus and the pituitary, there is thyroid releasing hormone, there is thyroid stimulating hormone, and from thyroid, there basically the T3, T4, and TSH are released. And in the peripheral circulation, with the process of deiodinization, from T4, there is active hormone T3 is formed with its conversion. And also an inactive form, reverse T3 is formed, which can be raised in many conditions, which will be taking into consideration. So hypothalamus pituitary axis in acute illness, which is called euthyroid sick syndrome or non-thyroidal illness syndrome. So what happens here is, we'll see from this chart only, that in critical illness, when there is euthyroid sick syndrome, reverse T3 will be more, but TSH will be almost normal. But if there is, so you have to differentiate this condition from primary hypothyroidism. So in primary hypothyroidism, the levels will be more, the TSH will be more, and reverse T3 can be low. So the clinical syndromes, there will be a medical history of hypothyroidism, then the primary hypothyroidism will be your diagnosis. So the crux is that when your T3, T4 levels are low in ICU findings during early phase of illness, of critical illness of any patient, TSH is normal, then you can think that this condition is a non-thyroid illness. There is thyroid is not involved directly in this patient, and hence you can go for the reverse T3 levels, which will be high, and making your diagnosis confirmatory as sick euthyroid syndrome. So we have learned that there is main axis is a pituitary, hypothalamus pituitary adrenal, hypothalamus pituitary thyroid, hypothalamus pituitary gonadal, there also, and fourth is your glycemic control in the ICU. So for them, for glycemic control, we all know that wide fluctuations is not acceptable in critically ill patients. HbA1c can be a good predictor or a prognosticator marker, and also diagnosis that how the glucose was in control in the last few months, and also in cardiac patients or in ischemic stroke patients, where we need to keep the strict glycemic control, also in septic patients. So only 2-3 biomarkers have been studied till now as a humoral biomarker of immunity, as we have learned that all these three systems go side by side. One is endocrine, nervous system, and immune. So from the humoral level, what biomarkers are available to judge the efficiency of endocrine system in ICU? One is leptin. Leptin, it sends signals for satiety and energy expenditure. Hence, it is responsible for all those anorexia and wasting characteristics in severe illness. Leptin is immunomodulatory and anti-inflammatory. It inhibits HP axis, which activates hematopoietic cells to enhance macrophage phagocytosis, and hence it acts as anti-inflammatory. Another factor which has been studied is macrophage inhibiting factor. It is released by the pituitary gland. It counteracts the effects of glucocorticoids, and hence these biomarkers, they are not used in a routine day-to-day routine practice. So the crux of all this presentation was to tell you that not to learn the whole extensive list of biomarkers, but just to know go through in detail the common biomarkers which we're using in ICU and how you can use these biomarkers in risk assessment, in diagnosing, in prognosticating, in seeing whether your therapy is going into right direction or not. So they are all as a help to you in the ICU, but not as a definitive markers of any treatment or therapy. Thank you.
Thank you, Bajinder. It was, I think, a very exhaustive but very crisp and to the point review of biomarkers, which how to use them, what is the background, and how you can interpret their temporal rise and fall. I think it was a very good learning experience for all of us. It's not that we just send the biomarker and if it is elevated, we come to a straightaway diagnosis. There are lots of caveats which, as you have mentioned, we need to keep in mind before we rely on a biomarker for our therapeutic decision making. Kancham?
Thank you, Bajinder.
Thank you, sir.
I think the way we are moving into critical care, where we are emphasizing more and more on precision medicine or personalized care among different clinical settings, I think biomarkers are going to be a major player in the days to come. We know that they have been very well established in cardiac, at least in cardiac pathologies, right? And they've changed the way we manage cardiac emergencies, especially with the availability of troponins and BNPs. And to a large extent, most of the literature where kidney biomarkers have been used have found to be, at least have some impact on the renal outcomes. I think sepsis is a pathology where there are multiple organs involved and different stages of presentation. So that's why probably we are going to find it very, very difficult to find a good biomarker for sepsis. But hopefully that we will also have some biomarker for sepsis patients which can be applied in majority of the settings. So I think as we progress into intensive care, the role of biomarkers is only going to be increased, and depending upon whatever biomarkers we are having at our unit, I think we should start applying them into whichever clinical context that can be applied, and then start utilizing them. Only then probably we'll be understanding them more. Thank you, Basjinder. I think it was a very, very extensive review. Thank you.
Thank
Over to
you,
you,
sir.
Srinivas.
Because we have to understand that if they are not diagnosed,
Srinivas, your voice is cracking. Srinivas,
they are pathophysiology specific markers. For example, if you look at the high sensitive troponin,
sorry
be
to
elevated with an intact myocardial. Can you hear me? You can't hear me.
you have to repeat everything because you'll have to start it again.
Why is that?
So your voice
Because
was cracking. We couldn't hear it
Achha,
clearly.
okay. So biomarkers, while we use them quite often, we should remember that sometimes they are not pathophysiology specific. For example, sensitive troponin. We know that it is a marker for inflammation, but that inflammation need not always be an infection. Patients who have coronary artery disease, who have a higher of their
Srinivas, we are losing you.
for after Am I audible?
No,
Am I audible, sir?
now yes, but again we lost the whole comment that you made.
Okay. So some of these biomarkers are pathophysiology specific, like highly sensitive troponin. Highly sensitive troponin, for example, in patients with coronary artery disease. If somebody has an acute coronary syndrome and at the time of diagnosis has a very high value of highly sensitive troponin, they are more prone. They are patients who should be subjected to longer duration of dual antiplatelet therapy because they are more prone for stent thrombosis and
I think I'll have to ask Srinivas to record. We lost you at stent thrombosis. We lost you at stent thrombosis.
Yes, yes.
Yeah, so similarly in subarachnoid hemorrhage, patients who have subarachnoid hemorrhage with a high value of highly sensitive troponin are more prone for vasospasm and delayed cerebral ischemia. So there are a lot of,
Something is seriously wrong with Srinivas's network today.
Yes, network issue is there.
I think we have some issues with Srinivas's network.
Yes,
Anyways,
sir.
thank you, Basjinder. Thank you very much.
Thank you, sir.
We will meet again next week, looking at the newer indications for the ultrasound in intensive care. Ultrasound again has become an inseparable part of critical care. So we will look at the newer avenues or the newer areas where ultrasound is making a big impact on the management of critically ill patients. Thank you very much.
Thank you, sir. Thank you for the opportunity. Thank you.
Okay, goodbye, and all of you have a great day.
Thank you, sir. Same to you.